So just a bit of background about me. I work at the Royal Brompton Hospital. It's the largest specialist respiratory hospital in the UK. And I'm indebted to this lady, Dame Margaret Turner-Warwick, who died aged 92 last year. But she had the foresight in the 1960s to set up our interstitial lung disease unit at the Brompton. And as a consequence of the founding work that she did, we now see about 1,500 new patients a year with fibrotic lung disease, which gives me the great opportunity to do lots of research to try and better understand this disease and also drive forward clinical trials. And so I'm going to try and share with you some of the insights that we've developed over recent years into idiopathic pulmonary fibrosis. So as background, IPF is a nasty disease that tends to affect people in later life. The average onset is about 65 to 67. As this CT scan shows, the condition is characterized by progressive fibrotic destruction of the lung, such that individuals with the disease almost inevitably die from respiratory failure. As you can see from the histology, what happens is that the normal lung tissue, that beautiful lace-like architecture that is designed for gas exchange, becomes replaced instead by fibrosis. And it's not only that there's a buildup of fibrotic tissue, but that fibrotic tissue actually destroys the structure of the lung, which is what impairs gas exchange and ultimately causes the symptoms and the respiratory failure that our patients report. Now, importantly, IPF is becoming more common. So in the United Kingdom, we've gone from about 2,500 new diagnoses back in 1990 to about 6,000 new diagnoses in 2010. And about 80% of people who have IPF die from IPF. So about 5,000 deaths a year occur in the UK due to idiopathic pulmonary fibrosis. And to put that in context, in the UK each year there are 500,000 deaths. So 5,000 is 1% of 500,000. 1 in every 100 deaths that occurs in the UK occurs due to idiopathic pulmonary fibrosis. So not truly a rare disease. And so one can assume that in this room, 1 or 2 audience members probably will die from idiopathic pulmonary fibrosis. Now, despite the importance of the condition, despite the fact that it's inevitably fatal, despite the fact that it has a median survival from diagnosis of approximately 3 years, we have until very recently seen little in the way of improvement in terms of outcome. So what this graph just demonstrates is that if you were diagnosed anywhere between the year 2000 and the year 2012 in the UK, your expected survival was 3 years from diagnosis. We saw no improvement whatsoever. And that contrasts with melanoma or breast cancer, where we've seen huge gains in 5-year survival over the last 10 to 20 years. And again, just to put this in context, if IPF were a cancer, its 5-year survival of about 20 to 25% puts it in the same ballpark as non-small cell lung cancer and things like stomach and esophageal cancer. So this is an important disease that affects more individuals than we perhaps realize, and it has a dreadful outcome without therapy. Why does the disease arise? Well, we've developed an increasing understanding. Despite the fact we call it idiopathic and pretend we don't know the cause, I think increasingly we're developing a deeper understanding of what it is that triggers the disease in specific individuals. And we recognize that scarring and fibrosis are part of the normal wound healing response. If you cut yourself, you trigger a cascade of events that should lead to healing. You start with bleeding, formation of a provisional clot, influx of inflammatory cells to clean out any bacteria and then to debride the wound. You then get expansion and proliferation of fibroblast numbers that produce extracellular matrix and a provisional scaffold over which the epithelium can regrow. And then once the wound has re-epithelialized, the whole process switches off, the wound regresses, and you get architectural remodeling and restoration of tissue structure and function. The same thing that happens in the skin happens day in, day out in the lung. And of course, the lung is exposed to the environment continuously. We're breathing in smoke, dust, pollution, viruses. All of these things are triggering microscopic injury. And so in IPF, what we recognize is that there is a component of genetic susceptibility, that there are important polymorphisms in genes that are involved in different parts of the wound healing process. So MUC5B is a mucin that is protective against injury. TOLIP is a gene that protects against cellular aging. TERT is similarly a gene that protects against cellular aging. We then know that individuals with the disease are much more likely to have been exposed to things that will cause injury to the lungs. So they're more likely to have worked during their life in a dusty or smoky environment. And what we think the key trigger is aging of the cells that repopulate the damaged epithelium in the alveolus. And so that final event is the senescence of those cells. And once those three things come together, it triggers activation of a whole cascade of intracellular and extracellular events that are normally involved in the wound healing process. This leads to an imbalance between pro- and anti-fibrotic mediators. This triggers the activation of various different cell types in the lung, particularly the fibroblasts, which then go on and produce extracellular matrix and collagen and perpetuate this process of scarring of the organ. And importantly, there seems to be a feed-forward loop. So the whole process of fibrosis begets more fibrosis. Once you've started down this route of developing IPF, it almost becomes a self-perpetuating process. So this is what we think happens in the condition, and that feeds into how the disease behaves in clinical practice. It is a condition that is inexorably progressive. Patients report ever-diminishing exercise tolerance to the point that they develop respiratory failure at rest. As with any condition, we see a spectrum of disease behavior. We see patients who go rapidly from first symptoms to death in a year to 18 months. We also see a smaller proportion of patients with more indolent disease who perhaps live 10 or more years following diagnosis. And then, of course, there's the average patient who, without treatment, dies within 3 years. We also then have this important additional phenomenon of the acute exacerbation. Now, as respiratory physicians will be au fait with acute exacerbations of asthma and COPD, where there's more cough, more sputum, often driven by infection, tends to respond well to treatment with antibiotics and corticosteroids. An acute exacerbation of IPF is different. The IPF lung is uniquely susceptible to epithelial cell injury. And an acute exacerbation of IPF is essentially an episode of acute lung injury occurring on top of the fibrosis. So these patients get widespread alveolar epithelial cell death, and they get a condition that's indistinguishable from ARDS that we see on the intensive care unit. So as an example, this is a 63-year-old lady who had very mild disease when we first saw her at diagnosis. 6 months later, she came back as an emergency to our clinic, reporting that in the previous 10 days she'd become rapidly more breathless. She'd gone from being able to play golf to now struggling to walk upstairs. And you can see that there's diffuse grayness or diffuse ground glass on the CT scan. We admitted her on the assumption she was having an acute exacerbation. Despite best supportive care, this is the CT a week later. And half of patients who have an acute exacerbation of IPF will die of that acute exacerbation within 30 days. So this is a terrible disease in need of much better treatment. So what treatments do we have? Well, we've always had lung transplant, but really this is for the minority. Less than 1 in 300 of our patients ever get a transplant, and that's because of limited organs and because the average IPF patient has comorbidities. And so happily in 2014 we saw the announcement not of one but actually 2 sets of positive phase 3 trials with Pirfenidone and Nintedanib. And so Pirfenidone is a small molecule. We don't fully understand how it works, but it probably interacts with multiple growth factor pathways. It was first studied in phase 3 trials back in about 2010 with the results published in 2011. And the challenge of these data were that the first study proved to be positive. We saw slowing down in the rate at which IPF deteriorated, but the second study was negative. And so at the behest of the FDA in the United States, A third study was done, and this is the one that was published in 2014. And this shows that pirfenidone halves the rate at which IPF gets worse over a 12-month treatment window. Of course, nothing in life comes for free, so pirfenidone does cause side effects, particularly nausea and photosensitive rash. And then our second drug is Nintedanib. This was developed as an anti-cancer treatment, principally for non-small cell cancer. It's a kinase inhibitor that blocks multiple kinases, including VEGF, PDGF, and FGF. And it was also found to have anti-fibrotic effects when tested on fibroblasts in vitro. And so as a consequence, there was a dose-ranging study undertaken and published in 2011. And this showed that compared to placebo, the highest dose of Nintedanib reduced the rate of decline in patients with IPF. And so this led on to 2 parallel phase 3 studies, which, similar to the pirfenidone data, show that treatment with Nintedanib in both studies halves the rate at which IPF gets worse over time. And Nintedanib, for its main side effect, tends to cause diarrhea and bowel disturbance. Now, you might ask, what is the relevance of slowing FVC decline? Well, ultimately, we think if you can slow the rate at which fibrosis accumulates, as measured by forced vital capacity, then ultimately you should keep patients better for longer, i.e. they should live longer lives with a longer period of time where they can still carry out day-to-day activities without significant breathlessness. And certainly when we've looked at open-label data and tried to answer the question of what does pirfenidone treatment add, we find that patients who can tolerate long-term therapy, when compared to age and severity matched patients who don't have treatment, that pirfenidone seems to buy back 2.5 years of survival. So if you take the patients in clinical trials who went into open-label studies, their median survival is slightly better, so it's about 5.5 years because they have milder disease. If you take the patients who start on pirfenidone and stay on pirfenidone, their median survival is now approaching 7.5 to 8 years. If you take a 67-year-old at random from the general population, however, they've got a 50-50 chance of living almost another 20 years. So you can see that although we've gained back life for our patients with therapy, we've still got a long way to go before we still restore a normal life expectancy for our patients with IPF. And so the question is, how can we move things forward? How can we discover new drugs? And so I'm just going to talk you through the sort of work we've been doing at our center to try and expedite new drug discovery. And one of the exciting things about IPF is there's lots and lots of different treatments in development. There's more than 20 different compounds being studied at the moment, all of them targeting different mechanisms in the fibrotic pathway. The challenge we have is that the drug development pathway is long, and traditionally in IPF, companies have gambled large and tended to go in at the phase 3 level, where trials cost in excess of £100 million. What we're trying to do is develop early phase studies so that we can sensibly pick from that long list of potential treatments and then ultimately try and fast track the development of therapies that might have additional benefit for our patients. And I put this up again just to illustrate that a phase 3 trial is 52 weeks long. It requires about 600 patients. It requires about 80 centers around the world. So these things are very expensive to run. If we can shorten them and make them smaller, then ultimately we can make it easier for new drugs to come to market. And then there's another salutary lesson. This was a negative study published recently of a monoclonal antibody targeting LOXL2, simtuzumab. Oops, sorry. And the challenge in this study, where they went straight into phase 3, was when it proved to be negative, we're left wondering why. We don't know if it's the wrong drug, at the wrong dose, not targeting the organ of choice, or not penetrating the tissue. And so when you end up with a negative phase 3 study, you're in the very unsatisfactory position of not knowing why. So again, we're keen to avoid this sort of study in the future, where almost 1,000 patients are given a drug for in excess of 2 years that then proves to be totally useless. So what can we do about it? Well, one thing we can think about developing is biomarkers. And biomarkers are a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacological responses to treatment. And whilst we tend to think of biomarkers as blood tests, they can also be imaging like CT scan, or they can be things like lung function tests. So a biomarker can be any test we use either to measure health, disease, or response to treatment. And so one of the pieces of work we've done at the Brompton has been the profile study, and this was a longitudinal study of newly diagnosed patients with idiopathic pulmonary fibrosis. We recruited, together with Nottingham University, almost 600 individuals with IPF, and then subjected them to a battery of blood tests and questionnaires and other things over a period of 3 years. And when we look at the blood samples from our IPF patients, what we see is there's a very clear protein signature in the blood of individuals with IPF that distinguishes them from healthy, normal adults of the same age. And so this is just a way of looking at about 150 different proteins all together on one graph. But what you see is the normals cluster over here, and the patients with IPF cluster over here. And furthermore, the patients with more rapidly progressive disease cluster separately. So it is possible to measure proteins in the blood that map with disease progression. Furthermore, if you look at the transcriptional profile of the white blood cells, so you take the white blood cells, you extract the RNA, and you look at the genes that are being used to produce proteins, you can identify a transcriptional profile that picks out patients with progressive disease. And this was work we collaborated on with Yale, where they were able to show that in 6 different centers around the world, this same profile picks out a group of patients with worse disease. And I'm not going to touch on personalized medicine. I think we're going to hear about that with the CF lecture. But this gives us a way to identify patients who may respond to different forms of therapy. And then an interesting piece of work we did was with a company called Nordic Bioscience, who've developed a set of bespoke biomarkers that identify collagen proteins that have been degraded by matrix metalloproteinases. If you think back to medical school biochemistry, when an enzyme cleaves a protein, it will always do so in the same site. So you can develop tests that will pick up the cleaved protein, but not the intact form. And so we did this with a series of extracellular matrix proteins. And to start off with, we looked at patients with IPF in blue and red and compared them to healthy individuals. And we find that many of these markers, out of a panel of 11, 8 of these markers are increased in the bloodstream of our IPF patients. Furthermore, this is an example of one marker, collagen 1 degraded by MMP. You can see that over time, patients with progressive disease show ever increasing levels of these markers, and it happens for multiple of them. And you could therefore imagine that if these markers map with disease severity, so these are 2 separate individuals, you can measure how things change over a period of 6 months. If these things get elevated as the disease progresses, then you would expect that this sort of patient is going to do worse than that sort of patient. And you can take the population of individuals, you can separate them into those who have rising levels and those with stable levels. And again, when we do that, we see that these markers predict people who are going to have better or worse outcomes. And again, this gives us information within 3 months of diagnosis about which group patients fall into, progressive or more stable. And so the next step is to see whether this works with treatment. And so we're currently running a trial with Boehringer Ingelheim, the people who manufacture Nintedanib, to do an interventional study where we're giving 3 months of treatment or placebo, and we're going to see what happens to biomarker levels. And so if positive, this will hopefully give us something to use in future trials. We've also done something similar with more traditional biomarkers. So these are cancer markers, CA19-9 and CA125, that actually are markers of epithelial turnover and proliferation. And we find a very similar story with those 2 cancer biomarkers. And so we're currently in a position where we're using sort of computational power to try and integrate these different biomarkers to maybe give us a simple scoring system that we can use in clinic to identify patients with progressive disease and those with more stable disease. And again, perhaps a way of guiding therapy and choice of therapy in the future. And then there's the question of how we use the tools that we've already got. So as I've told you, forced vital capacity is our tool of choice in IPF. patients who get worse over time show an ever ongoing deterioration in FVC. And if you dichotomize FVC based on change at 12 months, you can separate people into individuals who are going to do badly and those who are going to do better. And so Anne-Marie, when she first joined my group, helped run this study. But essentially, we gave 50 of our patients a handheld spirometer and just asked them to measure their FVC at home on a daily basis. What we do find is if you ask people to do it at home instead of the lung function laboratory, they tend to slightly underperform. So they underestimate their FVC by about 200 mils. So that technician screaming at them in the lung function lab is worth about 200 mils of extra FVC. Nonetheless, it doesn't matter that it underestimates. What we find is that having all that extra data tells us a lot more about our patients. And so you can see this is one patient who's measured his daily FVC for a year and a half. Every dot on the graph is an FVC reading. You can see that if you pick any two readings, say here and here, you can be misled into thinking his condition is stable. But in reality, things have got steadily worse over that 18 months. It's another individual who has very rapidly declining disease. This is the sort of patient who never comes back for that 6-month follow-up appointment, the sort of patient we completely forget about. And then this is an individual who's lost a quarter of his lung function over a 3-week period of time. So this is someone who's had an acute exacerbation during the study. And so we can sort of map out what happens to the average patient. The average patient loses about 12% of lung function over 12 months, but about a quarter of patients lose more than half of their lung function over that period of time. So these are the individuals with rapidly progressive disease. Again, we can use this to predict outcomes. And importantly, within 3 months of diagnosis, we can begin to separate those with progressive and more stable disease. And again, we're now testing this in a clinical trial. So this is with Roche using Pirfenidone in patients with unclassifiable disease. We're using the daily home spirometry as the primary endpoint to see whether we can translate this into clinical trials. And so very quickly in the last few minutes available to me, I'll just touch on how we're now using this in some of our clinical studies. So this was work done in collaboration with University College London and GSK, where we identified that PI3 kinase, an intracellular signaling molecule, appears to be important in driving the fibrotic response. And so we utilized a PI3 kinase inhibitor that GSK had to give it to humans in this proof of concept study. And so we developed a study where we gave cohorts of 4 patients either placebo or a PI3 kinase inhibitor, and depending on response, we then escalated the dose as we went along. We were able to use serial blood tests to show that the PI3 kinase inhibitor had important effects downstream. So it blocks phosphorylation of AKT, which is a downstream intracellular signaling molecule. And more importantly, we were able to do bronchoscopy and sample the cells in the lung to show that it did the same. Now, the challenge we have with a PI3 kinase inhibitor is it has lots and lots of side effects. They're used in oncology for short periods of time, but they're not realistically a treatment for patients with IPF who are going to have to be on therapy for many years. And so the next step is just to see whether we can give drugs by inhalation. And so this was a study using salbutamol just as a model drug, generating particles of very specific sizes and radiolabeling them so we could look at the pattern of deposition. And what we find in the IPF lung is that if you can make the particles small enough, or if you use a nebulizer and waste lots of drug, you can get peripheral deposition of drug in the regions of fibrosis. What's perhaps challenging is that as disease becomes more severe, as measured by FVC, the distal penetration gets worse. So we're going to have to think carefully about how we deliver drugs by inhalation to IPF patients. Nonetheless, we've done another study. This is a drug that came out of Edinburgh University, targeting a pro-inflammatory macrophage-produced protein called galectin-3. And we gave an inhibitor by inhalation for 14 days. And again, by repeating bronchoscopies on these patients, we were able to show that administration of the inhibitor by inhalation knocks down the level of the protein that we expect it to work on. But also importantly, when we look at circulating biomarkers, we also find dose-response relationship with reduction in those markers. So showing proof of concept data that we can deliver inhaled drugs to the IPF lung and have important knock-on effects on proteins of interest. And then finally, this is another interesting study currently published only as a press release, but shortly to be published, or currently in revision with Lancet Respiratory Medicine. But we gave an autotaxin inhibitor to patients. So this blocks one of the key fibrotic pathways. We were able to show that the drug downregulates downstream intracellular markers, but also importantly in a small proof of concept study, we were able to show that it has an influence on daily spirometry. And so just to bring it back, I think we're now in the exciting position where we can identify potential drugs in bold where we're beginning to accumulate evidence that they're more likely to be effective in IPF patients. And at least 3 of these are going to go into phase 3 studies later on this year. So in conclusion, IPF is a nasty, progressive, fibrotic lung disease that arises due to an abnormal wound healing response in genetically susceptible individuals who over their lifetime have been exposed to things that cause repeated alveolar epithelial cell injury. I think traditionally the drug development pathway has been very long and arduous, and hopefully I've shown you that things like daily spirometry and some of these blood-based biomarkers are going to allow us to change the way that we discover drugs in the future, and perhaps down the line will allow us to personalize treatment and also give us tools to measure treatment response in the clinic. And so I think we're in this exciting phase now where there are lots of things in the pipeline which will hopefully become a clinical reality in the near future. And so I'm grateful to the several hundreds of patients who've participated in my various research studies. They've been highly engaged, and we've had several study days to feed back the data, and without them we would never have done the research. And of course, it's very easy for me to talk about this as though it happens with little effort, but there have been a huge number of people who've been driving forward this research, and of course I'm indebted to them, and of course all the people who've paid for it. But thank you very much for listening.